everybody. Good afternoon. I'm Anjali Owens. I'm from the Center for Inherited Heart Disease at the University of Pennsylvania. I am a heart failure transplant cardiologist by training, and I spend most of my time taking care of patients who have genetic forms of heart disease, all different kinds of cardiomyopathy, and it's my pleasure to be here today.
Hi, I'm Orrin Cooper. I'm Number two. All right. I'm Orrin Cooper. I'm a pediatric pulmonologist, and I don't know what I'm doing here.
So we're going to have two speakers and then a panel, and he's our pulmonologist, so if there's pulmonary questions, and we have Jen for our geneticist, so if those kinds of questions come up, we're going to just thank you for being here.
Okay. Thank you for having me.
Hi, I'm Carol Whitley-Weber. I am a pediatric cardiologist at the Children's Hospital of Philadelphia. I am on the other side, across the street from Anjali. I also have a focus in pediatric heart muscle disorders. I'm one of the cardiologists that takes care of patients with heart dysfunction, and most of my clinical practice involves patients with different forms of hereditary conditions that could lead to heart muscle weakness over time, and that's how I've focused my practice for the last 10 years.
Hi, everyone. My name is Teresa Wang. I'm one of the adult heart failure transplant cardiologists over at Penn. I work with Dr. Owens and in the Inherited Cardiovascular Disease Center with a specific interest, in neuromuscular heart dysfunction.
Hi, my name is Zolt Harani. I'm an adult cardiologist at the University of Pennsylvania. And though I still see patients, I really spend most of my time doing fundamental research, trying to understand heart failure. We have had a range of interests over the years, including genetic cardiomyopathies. And for the last 15 years, we've been especially interested in what we'll talk a little bit more about, which is pregnancy-associated cardiac disease, in which Titin plays a role.
I'm Jen Rogenbach, and I'm a neuromuscular genetic counselor, so I too am in the what am I doing here category, but hopefully I can help address any questions about genetic testing or interpretation. Thank you.
All right, we'll get started. So we'll have a couple of talks with slides, and then we'll have lots and lots of time for questions. So think about your questions as we get started. And just as a bit of background about genetic forms of heart disease, we know that these conditions are actually much more common than you might think, and they're under-recognized. So what do we mean when we say a genetic heart disease? That means that anytime there's a misspelling or a change in your DNA code, it can lead to your heart being structured abnormally. And when your heart is structured abnormally, it can look a number of different ways. So we have pictured here at the top what a normal heart looks like. And then as you get further down, you can see a heart that has dilated cardiomyopathy. I don't think you're going to be able to do that. That's this one. Then we have hearts that become hypertrophic or really thick. And we can have hearts that just have a lot of electrical abnormalities or abnormalities of the right side of the heart. So your heart can look a number of different ways when you have muscle disease that's related to your DNA. And so what do we know about what the Titin gene can do to your heart? Well, the Titin gene can cause something called cardiomyopathy, and that's a really long word. Cardio is heart, myo is muscle. And as my mentor taught me, pathy means pathetic. So you have a pathetic heart muscle, and our job is to figure out why and try to fix it. And the kind of cardiomyopathy that we most likely see with Titin-related changes is what's called a dilated cardiomyopathy. And what does that mean? Well, here I have a normal heart. This is the right side, this is the left side, and this is the left main pumping chamber called the left ventricle. The job of the left ventricle is to squeeze the blood out to the rest of your body. And typically, it's shaped kind of like an American football. It's a little bit, elongated, and it's muscular. And when we see a dilated heart, it kind of changes shape to look a little bit more like a soccer ball. It becomes more like a ball shape, and it becomes dilated. And dilated means that internally here on the inside, it becomes enlarged. And you can see it's larger than the inside here. And these are things that we measure when we do heart ultrasounds and as we follow your heart over time. So this is what dilated cardiomyopathy means. And what we found by studying patients all throughout the world, all different ages, men and women, is that you can be born with that change in your DNA, that abnormal spelling, if you will, and it is there from the time of your birth. But at some point in your life, it may start to show up in your heart. And what we found over the years is that there are certain things in the environment that may trigger the heart muscle abnormality to show up. And what are some of those things that we've talked about? Dr. Rainey will talk a lot about pregnancy, so I won't talk too much about that. But we've also found that some people are sensitive to alcohol, others had received chemotherapy for a cancer diagnosis, others were taking medicines or other drugs that were stimulants to the heart. And we know, in particular with Titin-related cardiomyopathy, that it may take two things, a genetic predisposition and sometimes an environmental trigger to make the cardiomyopathy come out. In other patients, we never identify a trigger, but nonetheless, they show signs of cardiomyopathy. So how do we treat that? When your heart starts to get larger, it oftentimes doesn't squeeze normally. So generally speaking, your heart squeezes out about 50 to 70% of the blood with each heartbeat. And that's a term we call the ejection fraction. You'll hear that and see that on your echo. And it really just means how much blood is the heart squeezing out with each heartbeat. And it's important to remember, you're not aiming for 100 on this test. Normal is 50 to 70. But when your heart gets larger and it gets weaker, we find that that ejection fraction or squeezing function is too low. And how do we treat that? We have 4 medicines. We call them the pillars of our treatment because your doctors will talk to you about trying to get you on these medicines if your heart muscle becomes too weak. I won't go into too much detail here, but suffice it to say that these 4 classes of medicines have been shown to make you live longer, feel better, and improve your heart function. And those are the things that we're looking for in anyone who has cardiomyopathy that's dilated. So here's a picture of your heart. Let's see if I can get this little guy to play. This is when you have a low ejection fraction. You can see this heart, this is the left ventricle or the main pump. It looks kind of like a ball, and it's not squeezing very forcefully. And after we put medicines and have you take them, these are pills, you can go from having a low ejection fraction up to a normal ejection fraction. This heart looks more like a football, and it's squeezing much better. And one important thing that we've seen with Titin-related cardiomyopathy in particular is that they're very responsive to these medicines. So number one, we pull back on any of those triggers that could be making things worse. That might be alcohol-related or any sort of environmental thing we can identify. And number two, we put you on really good medicines to try to get your heart muscle stronger. And usually patients start to feel better. The other thing the Titin gene can cause is electrical problems. So the first problem I talked about was kind of a plumbing or a pump problem. Now let's shift to the electrical system of the heart. We know that it's important to have your heart have a coordinated contraction. And when your heart is not beating in a coordinated fashion in the top, it's something called atrial fibrillation. And so here I'll show you is the normal pattern, top to bottom in yellow. And now what's coming is atrial fibrillation. The top is beating out of turn, the bottom becomes irregular. And when that happens, you can form a blood clot in the top chamber of the heart because instead of squeezing the blood out with each heartbeat, it's beating like this. And that blood clot could go up to your brain or anywhere in your body. And if it goes to your brain, it causes a stroke. And so if we find that, we think about getting you back into the right electrical pattern. And we also think about whether you might need something like a blood thinner. The other kind of electrical system that we can see with Titin-related heart disease comes from the bottom chambers of the heart. So this is something called ventricular tachycardia. Certainly don't have to remember that name. We call it VT for short. But this is when the bottom chambers are beating out of turn. And when that happens and it's very fast, that can cause somebody to pass out or sometimes even die suddenly. So we take this one very seriously if we see it. And the weaker your heart muscle is, the higher your chance of having this abnormal rhythm. So for some patients whose heart muscle is really weak, we think about a device called a defibrillator. And I have a picture of it here. This is the most common type where you have a little device. It's put in surgically, so it is an invasive procedure. And there's a wire that travels down through your vein into the right side of your heart. And it's like having the paramedics with you everywhere you go. So it's not doing anything to you if your heart rhythm is normal, but if your electrical system goes haywire and you go into this fast, dangerous rhythm, it'll spring into action by delivering a little electrical shock. And it's like having the paramedics, you've seen that on TV when they have to paddle somebody. It does it from the inside and it saves your life by putting you back into a normal rhythm. So not all patients need these, but some might. And if end-stage heart failure develops, so again, this does not happen with everybody with Titin cardiomyopathy. Many patients are able to improve their heart function and live normal, healthy, good quality lives with medication plus or minus devices. But in the subset of patients who develop what we call an end stage of heart failure, where we're not able to get you better and your quality of life is bad, meaning you can't do any of the things you want to do, you're in and out of the hospital, then we have two options to prolong your life. One is heart transplant, where we actually remove the heart that's not working and we find a donor or a match for you and put a new heart in. This is life-saving, but it's really trading one set of medical issues for a different set of medical issues, because once you have a heart transplant, you have to take medicine to suppress your own immune system so it won't attack your new heart. So it really is a different kind of medical issue that you live with for the rest of your life. The second way we have to save your life is something called a ventricular assist device. We call those VADs for short, and it's a pump. I don't have a picture of it here, but it's a pump that's put into your ventricle, and your own pump, and it takes the blood, bypasses your heart so that it sends it to the rest of the body. And this is a pump that you live with, ideally for the rest of your life, unless you have significant recovery of your heart function. So we do have options if you reach the end stage of heart failure. Now, what else are we doing that's new and different? Well, we're starting in the lab, and Dr. Rainey will talk more about modeling heart disease from a patient's blood cells. We can try to see what your heart cells are doing. For example, you can see here, these are heart cells made in a dish. And then we can try to give new medications or test the heart with changing the DNA to see if we can improve the heart function. And then we can try and see if they look better. So the heart cells on the top are beating kind of slowly and not as forcefully, and the ones on the bottom are beating more aggressively and faster. These are things that are in the lab and ways that we have to do tests to find new drugs and therapies. Here's an example of one of our patients at Penn. This is not a patient with Titin-related heart disease. It's a separate cardiomyopathy called Lamin cardiomyopathy, also can have neuromuscular manifestations and come with muscular dystrophy. And this is a patient of mine. Her mom had died from AFib and a stroke and heart failure, and she had the same changes in her heart. She needed that defibrillator to save her. She had AFib, she had had a stroke, and she had a miscarriage, and she really wanted to carry a pregnancy. But when we did her genetic testing, which we do frequently and we'll talk more about, we found a variant or a change in her DNA that we weren't sure if it was the cause of her heart muscle disease. And since her mom had already passed away, we weren't able to see if that same DNA change came from her mom. We did check her dad, who was alive, and he didn't have it. So we were pretty suspicious it came from her mom, but we couldn't be certain. And she said, I don't want to have a child unless there's a way that I can prevent this from happening. And so we said, well, we're not sure we can use this DNA change because it's in a gray zone. We don't know for sure that it's the cause of your disease. And so a couple of my scientist friends, Dr. Rainey knows, did some tests in the lab, and they said, well, we know what happens with lamin. The nucleus of the cell gets really messed up. And so let's put this variant in to a cell on a dish. We took our patient's blood cells, and he reprogrammed them into heart cells. And we looked at them under the microscope. And I am not a scientist, but even I could say that these ones were messed up and these ones were normal. And so we were able to help our patient in that way so that she could prevent passing disease on to her child. The last thing I'll leave you with is there is going to be a new clinical trial. So this is in human beings with Titin-related cardiomyopathy. It's going to be coming soon. Myosin activators. That's a really long term, but all it really means is a medicine that makes your heart muscle beat more strongly. And we think that might be poised to help patients with Titin-related dilated cardiomyopathy. So it will be coming soon, hopefully to an institution near you. We will have it at Penn, so if any of you are nearby and a few of my patients are back there, we'd be happy to have you. So here is our team at the Center for Inherited Cardiovascular Disease. This is on the adult side. I do have one of our pediatric colleagues, Dr. Lynn, pictured at the bottom, but the rest of these folks are our adult cardiologists. Raj Jain over in the corner and Kiran Musunuru at the top were the two scientists that did that special work for our lamin patient. And you see here Dr. Wang, who will be talking during the panel. She's joined us several years ago on faculty and is really growing our neuromuscular disease patients. So that crossover when it's also your heart and your muscles. And so, we're really keen to see more patients and help in any way that we can. Thank you so much.
Trying to understand these diseases, not just in cells, but even in intact model organisms. And it's complex. But I'll try to tell you a little bit about the very specific context of pregnancy, which is something that, as I said, we've been interested in for a long time. And so, maybe nobody in the audience has had pregnancy-associated cardiomyopathy, but some of the lessons we learned from this are really applicable to all of Titin cardiomyopathy. And I don't have to tell you what the word cardiomyopathy means. Thank you. So the first thing I'll say is that pregnancy can be really risky for women. It's actually, it's an amazing period of life. Like we all, when we turn, 18 to 19 to 20, we're basically done changing. We're going to slowly age over the rest of our lives, but we're basically done changing, except for pregnancy. During pregnancy, mom dramatically reprograms to basically, feed what is essentially a parasite. And then deliver that parasite, right? And then suddenly, all of a sudden, it reprograms to feed that parasite from the outside instead of from the inside. So as I'm sure anybody who's born a child in this room knows, the hormonal changes are tremendous, and the developmental changes are tremendous. And it's a lot of things to keep in order, and so for that reason, it's a very risky period. And there's increased mortality during pregnancy in the United States and elsewhere. Actually, the United States more than elsewhere. We can talk about that. And there's racial disparities. We can talk about that if you're interested. But by and large, the first thing I want to say is that in the modern era, the number one cause of maternal morbidity and mortality is cardiovascular. Right? It's all sorts of different kinds of heart, vascular disease, strokes. And one of the things that happens is cardiomyopathy. Okay? And it's called peripartum cardiomyopathy. Peri means around, and partum means pregnancy, so around pregnancy, heart disease. This is its definition. It's defined as an ejection fraction. You just heard that term, an ejection fraction less than 45, which is not normal. So that means the heart is not squeezing normally. And it just appears out of the blue in a woman who's usually either late pregnant or in the first few months after pregnancy. This disease most often presents after pregnancy, not during pregnancy. And the heart, well, there's no good reason why that heart should stop functioning properly, but it stops functioning properly around pregnancy. It's much more common than we thought. Probably 1 to 1,000 to 2,000 deliveries in the world are complicated by this disease. So that's 1 in 1,000, 2,000 doesn't sound like much, but there's a lot of deliveries in the world. So this adds up to a big number. 100, 200,000 in the United States every year. And it's on the rise for reasons that we don't understand. It's happening more and more. There are many states in the country, districts in the country where this is the number one cause of maternal mortality. And ballpark. These are ballpark numbers. But half the women who have this recover. They get better and they go on with their lives totally normally. And then about a quarter don't, and they have to live with having therapy that Dr. Owens just outlined for the rest of their lives. And about a quarter get worse, and they have to go to the sort of advanced therapies that you just heard about, such as the assist devices or even sometimes transplantation. This is, we're talking about young women who are, who have a child on their hands now. So this is a pretty devastating disease that we've been looking at for some time. But the good news is that we can treat them, and women do get better by and large. And we can talk more about that. And again, here too, there are tremendous racial disparities, which again is another topic if you're interested, we can talk about. This was one study, just to give you a little bit of sciencey stuff. This is one study we did here. So Philadelphia is interesting. Philadelphia is a very, very large city. It's the 5th largest city in the United States. It's extremely heterogeneous. So about half of the United States is black, half of Philadelphia is black, and half is white. So there's a lot of racial disparity questions we can address here in Philadelphia. So this was a study that was done by those 3 people. I was loosely involved, overseeing it from the back, basically. And we asked, how do women who have PPCM in Philadelphia do, white versus black? And you can see the white women recovered 2/3 of the time. I told you it was half and half. They actually did better. But the blacks didn't, right? Not nearly as much. And when they did, even when they did, they took a lot longer to recover. And I can tell you, this is not for genetic reasons. We don't understand the reasons, but it's not genetic reasons. There's some socioeconomic context which is complicated for all the reasons you can think that leads to these disparities. But almost certainly not genetic. Okay, so this was the question that I came in with thinking about many, many years ago. Is what causes this disease? Why are women all of a sudden developing this disease? And I'll propose to you the stupid idea that 2 things must happen. You must get pregnant and something else has to happen. Okay, I realize that's a really stupid way of putting it, but it helps me thinking. Okay, let me talk about the second part first. What is the something else? And this is where we get into Titin. Because several years ago we thought, well, maybe the something else is that some women are predisposed to it for a genetic reason while some women are not. And so with the help of geneticists in Boston and several other people and really a large cohort of people, much like you have here, we were able to get a lot of patients together from around the world and sequence them and identify gene variants that would be more common in a group of women who had peripartum cardiomyopathy. And lo and behold, about 10% of them, actually probably more, 15% of them, had variants in Titin. So this is how we came to know that peripartum cardiomyopathy, a subset of peripartum cardiomyopathy, is in fact a Titinopathy, okay? So that, of course, led to all sorts of questions, and I'll just touch on a few of them, and I'm happy to answer more if you're interested. The first one is, what kind of mutations do we find? right? What kind of variants in the Titin gene did we find? Now, you've all seen pictures of the Titin. In fact, in the previous section, we had a question about this. So I'm happy to answer questions about that. I think about this all the time, so I can answer some of the questions that were posed beforehand if you want to revisit them. But, this is what the Titin gene looks like, roughly speaking, and this is the sarcomere, is the sort of squeezing part of the muscle. This is true in skeletal muscle, but also in heart. Heart also has squeezing muscle, right? And these variants, these mutations, were basically found all over the gene in these women with PPCM, especially over in the A band, but really, really all over. And we can talk about this distribution, but they were all over. But what was interesting, and this is also true of, we can come back to this, but it's also true of dilated cardiomyopathy that's not pregnancy associated. What was interesting is that all of these variants, so let me say this first. All these variants are called heterozygous truncating variants. So what does that mean? Heterozygous means that all of these women have a normal Titin and an abnormal Titin. None of them have two abnormal Titins. They're always one normal, one abnormal, always. Okay, that's number one. And number two, truncating means that the mutation is not a mutation that changes the sequences there and then leaves the rest of the protein normal. They're all mutations that basically stop the protein from being created there. So what you get if you have a mutation here is a protein that looks like that. If you get a mutation here, you get a protein that looks like that, and so on, right? So they're pretty deleterious. By and large, they're pretty deleterious, right? So you have one normal and one really deleterious. And what's interesting is that when you have that equation, so to speak, one normal and one pretty deleterious, you tend to get cardiac disease, not muscle disease. Do we know why? I don't think so, but that's the truth, right? So by and large, these are different. So this is part of the reason why, even though they're titinopathies, the cardiac titinopathies are not quite the same as the skeletal muscle titinopathies. It has to do with the gene makeup. And I'll be the first to tell you, we don't completely understand that. But this is where some of that difference stems from, okay? Does it matter to clinical outcomes? So of 85% of the women who have pericardial cardiomyopathy have either some other variant or no variants that we can identify in any gene, and 15% have a variant in Titin. Do they behave differently over time? And the answer, I won't show you any of the data, but as far as we can tell, no. So they respond to therapies pretty similarly, although we don't have as much data as we do in the dilated cardiomyopathy context. But they seem to do, they have the same risk of getting worse or getting better, and they respond similarly to the therapies. But we don't have as much data as you do. This, of course, leads to, if they respond the same, why should we take a test anyway? Why should we look for the gene? If it doesn't matter to their response, we're going to treat them the same way, and they're going to have the same outcomes. Why should we genetically test them? And I would argue that there's lots of reasons we should genetically test them, and I actually wrote an editorial a number of years ago about that, including the idea that family members want to know if they're at risk. Sisters want to know if they're going to have a child, whether they're at risk. They want to know whether they're going to pass on the risk. There's lots of reasons that you should get a genetic testing beyond the fact that it's not going to change what you do as a physician to take care of the patient. So I'm happy to talk more about that. I won't for the sake of time right now. This is an important point. If you have one of these variants, and this was touched upon in the previous section, if you have, I just showed you that 15% of the women with PPCM have such a variant. So if you have a variant, your risk of developing the disease is up 20-fold. But does that mean that if you have the variant, you're going to develop the disease? That's a different question, right? And the answer is actually usually not. And the reason is because there's so many of these variants around, right? So this is a study, and this was, again, if you'll remember, this was in the question and answer, this was touched upon before. We did a study looking at really most of the northeast of Pennsylvania. This was with the people that are listed there. And we looked at 60,000 people. So we sequenced 60,000 people. That's a lot of people. And in those 60,000 people, we found tons and tons and tons of truncating variants in Titin. So deleterious people who are walking around and have one normal and one deleterious mutation in Titin. The very same mutations that were found in the PPCM, women with PPCM, and women with DCM, right? And yet they're walking around and they don't have a diagnosis. Almost none have any diagnosis. And many of these people had had ultrasounds of their heart for other reasons, because nowadays when you walk into your doctor's office, you get an ultrasound of your heart, usually, for some reason. And most of them didn't. Only about 10% had an ultrasound that was abnormal. So this gets back to the point that Dr. Owens was making. It's not just having the gene. There are other hits that have to happen. And pregnancy is one of them. Alcohol is probably one of them. Chemotherapy is probably one of them. But even when you have two, there's plenty of these people had children and still didn't have disease, right? So it's probably more 3 hits, 4 hits. And we don't actually really know what they are. But there's a lot of environmental factors that are playing into triggering these diseases. So the answer to this last question is a resounding no. It turns out these variants are very, very common. And part of the reason they're very common, by the way, is because the gene is so big. So the chance when mom and dad, mix their genes together and make an offspring, there's a pretty good chance that a mistake will have been made in this gene because the gene is so big. So it's a game of statistics. Fortunately, that frequent event usually doesn't cause problems. Every once in a while it does. And the combination with environment is what triggers it, but we don't totally understand that part. And the last thing I'll say, I don't know if I'm going over time or not, hopefully not, is the first one, right? So you have this environmental hit. There's an environmental reason for these women with truncating variants to develop the disease. And it's pregnancy, but it's not all pregnancies, but it's pregnancy. What is it about pregnancy that is doing this? And I'll tell you, the textbook, so to speak, or the way most people thought about it 30 or 40 years ago, is that, well, pregnancy is hard on the heart. Heart's got to work harder during pregnancy, which is true. But these same women are going exercising, and they're not getting cardiomyopathy from exercising. And the disease, as I told you, happens after pregnancy, not during pregnancy. So I'm going to summarize many years of research into one slide. We don't think it has anything to do with the heart working hard. What it has to do, coming back to the very beginning of my talk, is it has to do with mom getting reprogrammed. It has to do with all the hormones that are coming from all the different parts of mom and the placenta to reprogram her, and they're basically messing up the heart. They're making mistakes in how they reprogram the heart. So for example, again, I don't want to go into details, but the pituitary, which is a hormonal center in the middle of your brain, secretes all sorts of things that make, for example, mom get ready to lactate, and mom lactate when mom breastfeeds, right? Those hormones can have bad effects on the heart in special circumstances. The placenta, which is the sort of interface between mom and fetus, the placenta is actually a huge hormonal organ. It secretes all sorts of things into mom, and it's basically reprogramming mom, as I said, right, to take care of fetus and placenta. A lot of these hormones can damage the heart when there's too much of them or in the wrong ratios. So we're beginning to understand that this somehow is interfacing with a Titin truncating variant and causing disease. So you can see that a lot of what I've said is we don't really know what's going on. And this is the nature of research. So that's all I'm going to say, and then we'll do Q&A. But the take-home message is that much like dilated cardiomyopathy, in peripartum cardiomyopathy, 10 to 15% have these truncating variants, these one good and one pretty severe copy of Titin truncating variant. And that in addition to that, somehow pregnancy is causing hormonal damage to the hearts that's synergizing with that, that's mixing with that and causing disease in ways that we are still trying to understand. The last thing I'll say is that a couple years ago, with Jen Louie and Sarah Thorsden, we started a registry. Anyone who has, and this is not Titin-centric necessarily, this is just peripartum-centric, but we're trying to get, because this disease is relatively rare, and because we need more information from you all, from the patients, to try to understand exactly what this disease normally progresses like and what are the things that work and the things that don't work. We've started a registry that's picking up steam. It's web-based, so you just go to the webpage, and so tell your friends, and you can just sign up, and it's self-explanatory. And it's also a source of information, so we also provide information on that website. That is the last thing I'll say. I have a great team. I won't, it's really fun. This is the real reason I go to work. And so we can do Q&A. There we go. Okay, so yes, we've worked with Dr. Presser quite a bit on, and I guess some people here know Dr. Presser, or he's spoken before, maybe. Oh, okay. So Dr. Presser is another scientist at the University of Pennsylvania who specializes in these in muscle myopathies, not just heart, but including heart. So we've been interested in trying to understand the precise mechanism of how these titinopathies occur. And so I'll say a couple of things. I mean, the first thing I'll say is that we're not really sure yet, but I'll say a couple of things. The first one is that the way it works, the way the disease is caused in the heart is almost certainly different from the way the disease is caused in skeletal muscle, which is consistent with the fact, as I told you before, that the mutations are different. In the heart, as I said, there's one good copy, and then there's one pretty severely affected copy. Okay, so you can hypothesize two different things. One is you need two good copies, and one good copy is not enough. And by and large, we think that's probably the answer. So half Titin is not enough. You need 100% Titin, not 50 or 60% Titin. The other possibility, though, is that this little truncated piece is just wreaking havoc, right? And it's not that you only have half as much Titin, it's that you have this thing that's wreaking havoc. And there's some evidence for that being true. So the field doesn't know for sure, although we, Dr. Presser and I, favor the first. But it has implications on therapy. Because if the problem is that you need more Titin and this thing is inconsequential, then the solution is to just boost Titin production. And some companies, and there was a previous question about whether there's actual things going on therapeutically, and there are, but it's in stealth mode. So it's secret companies that are not yet revealing what they're doing. But there is a lot of activity. It's just under the hood or whatever. So that's being taken as an approach. If this is the problem, then you have to somehow remove it, and that's a much more challenging problem. So not only do we think the first answer is the right answer, we hope the first answer is the right answer, because it's easier to treat. So, yep.
Thank you. So I'm gonna, I guess I'll use the microphone.
There's this other one we can use for questions.
So thank you for both of you for your talks and for your work. And I'm going to go ahead and open it up to the panel. So if you want to just go down and down the line of the panel, and if you have any comments that you want to open with about what you know about Titin, what you've seen with some of your affected families, what some of the key messages based on your clinical experiences that you'd like to share with our families, and then we can just have the families open up to questions. And just remember, so we have perspectives from the research side, the adult, and also pediatric perspectives, and also someone who specializes in working with cardiac care for people with neuromuscular conditions, which is, you know, really special for us to have all this expertise here. So.
Okay, hello. start on the pediatric side. So we have the great pleasure of partnering with our colleagues at Penn, and so often we will screen, we'll do cardiac screening for children who carry Titin variants. Our screening is common to the tests that Dr. Owens mentioned to you. So if we have a child with a Titin variant, we will do a full cardiac evaluation, which typically includes an electrocardiogram, screening the electrical activity, and an echocardiogram looking at the heart function. I would say for us on the pediatric side, having a pediatric patient who has a Titin variant that progresses to severe heart failure, needing the therapies that Dr. Owens mentioned would be very rare. We have seen it, but I would say probably uncommon. So a lot of what we're doing is educating families, screening the children, providing guidance as they age. If we find a child with dilated cardiomyopathy from a Titin variant, we use the same medications that Dr. Owens mentioned. We benefit from a lot of adult heart failure literature with regards to the medicines we use in children. We've, of course, do our own studies as well in certain populations of children. But I think we screen similarly to what Dr. Owens mentioned. And again, it's a pretty uncommon cause of severe heart failure in our pediatric population.
I'll echo what Dr. Whitley-Weber said in that I think from a clinical and a practical standpoint, screening is super, super important, whether it's the pediatric or whether it's the adult side of things. What we say is, and as you've heard, genetics is tricky, right? Not everyone who demonstrates a variant is going to demonstrate disease or going to develop disease. And then even in the folks that develop disease, the range of symptoms can be very wide. Some people can be extremely minor, some people can be extremely severe. And so I think that's where the importance of screening comes in, that if you know you have a variant or a family member has a variant, in this case, ignorance is not bliss, right? This is knowing that you have it and getting appropriate screening through these cardiac studies allows us to have early diagnosis, close monitoring, and therefore ability to improve quality of life and symptoms on the back end. And therefore it also improves symptoms and knowledge for the family in general. So I'll just make the point that I think screening is extremely important in this case.
I'm just going to sit up here if you don't mind. So Dr. Kupfer is our pediatric pulmonologist here today. And one of the things I wanted to mention is that for some people with Titin-related skeletal muscle weakness, they have breathing muscle weakness and may end up on breathing support. And the other thing I wanted to say is that for people who might have untreated breathing muscle weakness, that it may put additional strain on the heart. And the last point you could address is I have seen people on breathing support that is not the right support and causes a different kind of strain on the heart.
How much time do I get?
90 seconds, the standard.
The industry standard, 90 seconds to explain a complex topic. Those were beautiful talks, by the way. Yeah. I learned a lot, so thank you. So, questions? What was it? So yes, some people with Titinopathies also have respiratory muscle weakness. That's a skeletal muscle, so separate from the heart, similar to your thighs, your arms, your shoulders. Those muscles are absolutely necessary for breathing. It turns out the lung is a very passive organ. It does not move itself. The muscles and the rib cage and the spine are what move the air into the lungs. So if you have weak muscles, you can't draw air into the lungs, and you potentially need help doing that. In terms of the correct respiratory support, it's always bi-level support, commonly known as BiPAP, but we should call it non-invasive or invasive ventilation. And the reason for that is you need both some pressure to stent the upper airway open and to keep the chest a little bit inflated, but then the work that the respiratory muscles do is to actually draw air in, so you need a second higher pressure to drive the air in. And that's why we call it ventilation. It's not just CPAP or continuous positive airway pressure. It's bi-level positive airway pressure or non-invasive ventilation. So if you're on CPAP, even if it's quote unquote just for sleep apnea and you have a titinopathy, you should not be doing that. You should be on bi-level support. And then in the setting of heart disease, a restricted chest, a small chest that can't expand, places more strain on the heart, especially the left ventricle, which is often the sickest part of the heart in titinopathies. So if the chest does not expand, the left ventricle also has less room to expand to receive blood into it that it can then pump out. So you may actually have perhaps even a preserved ejection fraction because the blood coming into the heart is a smaller volume, and so what it squeezes out is a smaller volume, but that ratio, the fraction, is quote unquote normal, 50 to 70%. So if you or your loved one has titinopathy and needs non-invasive ventilation, which we can talk about how to determine that, it can help support heart function. It's not going to change it, it's not going to reverse it, but I would say the fifth pillar is non-invasive ventilation. And our cardiologists at my institution frequently send me messages like, please get this patient on BiPAP because their heart function is worsening and we don't know why. They're taking their medications, everything is the same. Could it be a breathing problem? So I think that was less than 90 seconds.
Thank you. I also wanted to mention that we have some scientific poster presentations for this conference, and they are actually on that monitor and on that computer. And one of them is actually this really beautiful poster that was done by Dr. Diane Fatkin, who is a cardiologist really focused on Titin-related heart health. And her team submitted a poster on alcohol and its impact on heart health. And it's really, I think, really beautiful poster, so you could check it out. There's another poster on there about diagenic causes of titinopathy, which was also on there. And there is one more that I can't think of at the moment, but there's 3, so we'll check it out. And then Jennifer Rogenbach is a genetic counselor, and one of her, and you can talk more about it, but one of her focuses of her research is expanding, and this is our understanding of how single variants in Titin are increasing our understanding of autosomal dominant skeletal titinopathies.
Yes, so I am a neuromuscular genetic counselor and have come to this space having identified single Titin truncating variants in people with unexplained skeletal muscle presentations, which are mild but progressive, and in many cases these variants segregate with disease. So I think we do have some evidence that in some truncating variants, the skeletal muscle is affected, and I'll be talking about my research in the conference tomorrow morning and then again on Monday for the scientific session. But it does appear to be a minority, and most of the affected families have truncating variants in the A band, particularly exon 326, which of course is a commonly affected exon in general. But so far we don't know why some seem to have this skeletal muscle presentation in addition to DCM or arrhythmia later in life. But typically the skeletal muscle weakness presents earlier, though it may not bring the individuals to medical attention. It might go back to childhood, or there might be an elevated CK, or someone might get excluded from military service due to inability to perform push-ups or something like that. But that's one thing that I think is becoming clear, that particularly on the skeletal muscle side, we don't have enough categories for the spectrum of titinopathies that seem to exist. And that can be challenging for families in search of a diagnosis and also for their care providers. But just to get back on my genetic counselor, genetic testing soapbox, I do think it's really important to seek a genetic diagnosis and not to accept other diagnoses necessarily at face value in the context of a titinopathy variant being identified. So I've had many families whose relatives might have been diagnosed with alcohol-related cardiomyopathy or post-viral cardiomyopathy or some other explanation given. I think that in those cases, it is important to try track down the variant in the family if possible. And I even saw a paper, which I haven't read yet, that seemed to suggest that Titin variants were more common in ischemic cardiomyopathy as well. So I think that families can potentially advocate for genetic testing, but it might take persistence given what's in the literature and what's been historical practice.
The plot thickens. So I'm going to open it up to the audience for questions. Yep.
Thank you all for everything that you're doing in the research. So my son has severe cardiomyopathy, Titin mutation. His ejection fraction is 16. Most recently, and he's got a clot in his ventricle. Is there, and he just sees a normal cardiologist that specializes in severe cardiomyopathies. Is there a different path that we should be thinking about in terms of the Titin aspect of it? The cardiologist is aware of that, but is there a different path of treatment that would apply to Titin patients than normal cardiomyopathies?
So, though the Titin variant is obviously relevant to the why part of when we're diagnosing someone with dilated cardiomyopathy, it doesn't change how we manage them. A patient with severe ventricular dysfunction like your son has would be on 4 or 5 different heart medicines, the medicines that Dr. Owens mentioned. With an ejection fraction that low, one consideration would be the presence of arrhythmia, heart rhythm disturbances, and discussions about things like an ICD, like Dr. Owens would mention. And then depending on how limited your child is from that ejection fraction, it may make sense to talk to a cardiologist, if yours isn't, that does heart failure and heart transplant specifically, to make sure we have a full understanding of how limited your child is from it and what options are possible and would make sense for him. And that list would include the ventricular assist device and the heart transplant. So in the pediatric world, usually a heart muscle cardiologist is a heart failure, heart transplant cardiologist. So thinking in that lens, it might not. So it's important to ask the question. And then as your child becomes an adult, a young adult, 19, 20, 21, making sure there's a transition to an adult cardiologist that has that expertise as well. So depending on how old your child is, that transition period is really, really important and can be a sensitive time, and making sure you're connected with the right adult cardiologist as well.
Yeah, I appreciate all that. He's 21. He was
Okay.
diagnosed when he was 18.
Okay.
So right
You spanned
at
the,
transition.
yes.
He does have a defibrillator implanted. In terms of thinking about the severe therapies process and getting on the transplant list, knowing that the Titinopathies are a progressive disease typically, should he be on the list earlier? Should all Titin people that are sort of losing the ejection fraction, should it be an earlier process of getting on that list and into the therapies protocol?
That's a really good question. So as far, and I'll let them speak. Your son is 21 now, so that's them. But when you talk about heart failure and indications for heart transplant, it's not just the ejection fraction. Patients can be well compensated with a low ejection fraction. So it's a complex sort of discussion and evaluation. So we don't put patients on the list just when their ejection fraction drops below a certain point. And then when we're talking about heart transplant evaluation, as they will mention as well, it's a multidisciplinary evaluation to understand, is the heart just the problem? Are there other problems? Is the heart transplant going to change the larger trajectory of quality of life and quantity of life? And so it's not just the ejection fraction. And so that's why it's not sort of as if this happens, then list for transplant. It's much more complicated.
Yeah, I think Dr. Whitley-Weber broke it down quite well. So certainly I think the priorities would be making sure that you have some sort of transition plan to an adult heart failure transplant cardiologist upcoming, and at least having that ability to get them in, to have them develop rapport with a cardiologist that you guys are happy with. And then it depends, there's a lot of objective evaluation that goes into whether someone may be eligible or needs to go to heart transplant, beyond just the ejection fraction, like she's talking about earlier. And so, and that can take some time. When we talk about heart transplant, it's not so simple as just getting them on the list. There is a pretty extensive evaluation period that's exactly multidisciplinary, and it involves meeting not only cardiologists, it means meeting surgeons, it means meeting allied health services like social work, pharmacy, financial counselors, et cetera, because it's not a trivial thing. And so that can take time, especially on the outpatient side. And so early, getting in as early as possible to develop that relationship and understand what that process is, and having them be able to guide you through that and support you through that, I think is very important.
So there are 2 tests that you should talk with your son's physicians about. One is called a CPET, or a peak VO2 test, if they haven't already done that one. And then the second would be the right heart catheterization, where they check the pressures inside the heart. Those 2 tests give us that objective data to know whether we're headed to transplant or not. And so those 2 tests, generally speaking, are done more in academic transplant centers, and it's important to get those early. That way you know where things are headed.
I just want to add a little, something a little bit different, but you talked before about self-advocacy. And your son is lucky because clearly he has you as an extremely strong advocate. Our health system is a little bit fragmented, and so sometimes people don't know what's going on over there. And although you heard that, from our discussion, that right now there are no therapies or treatments that are specific to someone with a Titin truncating variant, that's going to change. And I can't tell you exactly when or how or where, but it's going to change. And my guess is that if you keep your eyes and ears and fingers open and Google activity on, you're gonna hear about that potentially even before your physician does. And so I advocate that everyone should do that. And there's nothing wrong with going into your doctor's office and saying, I read this, trial going on over there. How can I get involved?
So one of the things that I heard you saying at both the adult and the pediatric level is that the standard of care for treatment for heart conditions is similar for typical patients or patients with Titin variants, right? The other thing I wanted to point to is that your local cardiologist, you may consider needing care above your local cardiologist. And so in the DCM Foundation, they have a web page that says how to find a cardiologist expert. And they have search terms and some recommendations for how to find someone locally. And I will ask you guys not to, local cardiologists are an important part of everyday care for people. And then there's people who need specialized care. So I would ask if you could say a few words about that. And that is a resource on the DCM Foundation website on how to find a specialist, because it might, if you have a Titin variant and you might not getting the surveillance that you want, or you go to and I've totally seen this where people bring their genetic test results to their cardiologist and they just have no idea what to do, or they literally say, like, why are you here? And so I'm going to ask you guys to talk about that.
Sure. So we very frequently do what's called a shared care model where we see patients as a highly specialized center, but we share our care with the very important local cardiology team. So it's good to have somebody locally that you can see if you need something. If you end up in a local hospital, that person can be your quarterback to get you up to a higher need if you have to come down to the big hospital. So we frequently share care. And one of the things that we've seen patients do very successfully is seek a consultation at an expert center and get the game plan, get it written down and get it transferred and, spoken about with your local team. And then oftentimes that local team can carry that game plan and execute it. And as long as things are going well, you don't have to frequently come back to the main center. But if there's a time where things aren't going well, then you have that contact, you come right back into the main center. And if you need something more advanced that the local team can't do, you've done it. And we make that plan. And for the most part, we follow the guidelines for standard dilated cardiomyopathy. But there are some times where we may go off the script because we've seen a lot of patients with X type of genetic cardiomyopathy, or we suspect that there may be more arrhythmia or something else going on like a skeletal myopathy. So there are some nuances to care that you might get when you see that expert center. And so is it worth a one-time consult if you're able to do it? Just again, get that game plan written down. Any nuances can then be addressed and then go back to the local team for a shared care.
Yeah, I think that was great. I think just to add, we are all very fortunate to be at large academic institutions in a large city, Philadelphia. Not everyone lives in a large city that has a large academic center. I think a local cardiologist is very important. I fully support the shared sort of decision-making and shared care. In the pediatric world, though, if we are pursuing, let's say, advanced heart failure therapy options, we would ask a patient to have all of a multidisciplinary evaluation at our center, right? Because we need to ensure we have the team all working together. And then if we are following through and offering and doing an advanced therapy like a ventricular assist device or a heart transplant, all of that post-care would be at our center or a center similar, closer to you if you came farther away. So the local cardiologist might be would have less of a role in the pediatric world if we were pursuing advanced heart failure therapy options. But prior to that, we very much do what Dr. Owens said. We'll see a patient, maybe let's say we alternate visits, local versus at our center. I think a local cardiologist is very important, but I think to be an advocate, as was brought up, if you feel like you're not getting your questions answered at your local cardiologist, ask more questions. Use the resources that she mentioned to find a cardiologist at one of the specialty centers to get your questions answered. So I think be an advocate if you feel like you're maybe hitting a wall with your local provider.
Yeah, and I'll say that, this field, I think in general with Titin as well as other neuromuscular cardiomyopathies and everything sort of within genetics is rapidly evolving. So things that we know now, we didn't know 10 years ago, we didn't know 15 years ago. And so I think that it's, there are definitely things that I don't know, and you don't know what you don't know. And so just like Dr. Willie Weber said, if you're hitting a wall, certainly advocate for yourself. I wouldn't expect, necessarily all of our colleagues in the local community to know every aspect of Titin or to know every aspect of muscular dystrophy or myopathies. I don't even know all of it. And so it's important to really advocate and really lean on your patient advocacy organizations for that as well, because they have the avenues and the pathways to get in contact with people and help advocate on your behalf as well.
I can't believe it, but the time is ending. So I just wanted to, what, we have half an hour?
5:30.
I have two questions. All right, I have one. One
We
question.
have 30 minutes left. Go ahead.
Two questions. So the first one, I have a 10-year-old daughter who has no symptoms of anything, but she's been being monitored by a cardiologist due to our genetic. She has one variant. So recently they found that she had, let me see if I get this right, the abnormal thinning of the left ventricular myocardium. They kind of just said continue to monitor her, but she's very active in sports, and I just want to know if there's anything else I should be doing, any further testing or other things we should be watching out for.
I assume she had a cardiac MRI, and that's how they told you, or what?
It was
They
just
told you the echo.
EKG and echo.
So the echo, so they thought that the left ventricular wall appeared a little bit thin. And what was her heart function at the time of that echo?
Which function are you talking
The ejection fraction
I
or
believe,
fractional
if I'm reading this
shortening.
correctly, 69%.
Okay, so I think for a child of your age, if I were seeing them and thinking that the muscle looked a little bit different on an echocardiogram, I might consider an imaging modality called a cardiac MRI, because I think it gives us much more detailed assessment of the heart muscle. Given that she has normal heart function, I would feel fairly reassured with her playing sports. I would also maybe consider an exercise stress test where we have her exercise on a treadmill or a bike and watch her heart rhythm and heart performance. But with a normal ejection fraction, no symptoms, I would feel good about her playing sports, would just think of some other testing just to get some more information.
Is the cardiac MRI the same as the adult one?
Yeah, in the meaning like MRI scale. We
I
don't
don't,
have
I don't know
open
if she could sit
MRI.
still that
So
long.
she's 10.
'cause
So
it
she's
took
10.
hours
so
for me.
10 is the earliest age we start talking about doing them without sedation. If she can't do it without sedation, I might hold off and then do an exercise stress test and get that information and then sort of watch her from there.
Okay, thank you. And then my other question was, you were talking about the different hormones from pregnancy affecting the cardiomyopathy. What about menopausal hormones?
That's a really good question. There's by and large, with some exceptions, menopause isn't a problem of having more hormones. It's a problem of having fewer hormones. There's no evidence that I know of that there's a sudden increased risk of cardiomyopathy at menopause. I don't know if you know, but I've never. Yes. Yes. But that's a different, right, yeah.
There might be greater risk for your husband.
Well, I'm not going there.
Hi, Debbie Scheiber, and my cardiologist is sitting right there, Dr. Owens.
You've heard this a million times. You didn't have to.
I was in not good shape when I ended up at Penn several years ago, and I've had some ebbs and flows. My daughter ended up there, and we found out that she had the Titin protein mutation. She had flipped her car, supposedly had sudden death when that happened, and came back from the bag hitting her chest. And I took her straight to Penn. I had already been dealing with cardiomyopathy for years, unknown etiology. So we found out that she had the Titin protein mutation and the TTN, and then did the blood work on me and found out that that was my reason. I also did have chemotherapy, and up until today, I didn't realize that also could have turned the gene on. I had osteogenic sarcoma, and I was treated with the big guns, the Adriamycin and the cisplatin, which definitely could have, done something to the genes. But my question for you is that both of us, my one daughter, who's 33, I'm 63, are noticing that there's a lot going on with our bodies, and we're starting to put two and two together that we might have a myopathy. So Dr. Owens just referred me to neurology, to a neurologist at Penn who actually specializes in and knows a lot about the TTN mutation. And my daughter, who has been searching and searching and searching for answers to a lot of the issues that she has in life, she'll be here tomorrow, She's a teacher and she's exhausted when she gets home. She does have cardiomyopathy, but she has a much better ejection fraction than me. So I try not to compare the two of us at all because there's 30-some years in there. But we're now wondering whether or not any of this has to do with more of a myopathy. I've had like 4 falls in the last 2 years. And I have muscle weakness that I never had before. So I think it's just really interesting how we're now putting this together and tying it.
I personally think it's under-recognized, and, Jen
Yeah.
brought this up. I think when you're seeing predominantly cardiologists, we're not as focused on doing that neuromuscular exam in the way that we should, and we may chalk up some symptomatology to a cardiac dysfunction where it's really not, or it's both. And again, it may not be so overt or so severe that it brings you to medical attention, but when you ask the questions, it's there. And I think we're recognizing this more and more. And so we've started sending our patients over to our neuromuscular team as well. And I'd be fascinated to see what we find once we really take a close look at all of our Titin cardiomyopathy patients.
Yeah. Thank you. Thank you for being here.
Also mention that there was a study published a year or 2 ago by a Belgian group where they took a cohort of individuals with Titin-related DCM, and they did quantitative MRI of the fat in their muscles and also did a battery of strength testing. And they basically showed that these individuals, and they actually screened out individuals who had like a history of myopathy, they had increased fat content in their skeletal muscle that was significant. And they also had evidence of subclinical or mild weakness. And again, this is a cohort that was ascertained on the cardiac side. So I think we do have evidence that the skeletal muscle can be affected. What I don't yet know is it simply a spectrum, and some people are more at the severe end of the spectrum with more weakness, and then some people don't have any recognizable skeletal effects, or are there actually something distinguishing the people who have the skeletal weakness from those who don't? So that's something that I'm interested in looking into, but I think that we do have to be cognizant that sometimes people with Titin truncating variants do get skeletal muscle weakness when they only have the one copy. And these conditions can segregate in the family in a dominant pattern, because we do see also clustering of this multi-system disease in families. So stay tuned, because I think there's more to come.
There's a question right here.
Can I? Yeah. This question is for the pulmonologist. So my son has been diagnosed. He's 7 years old, but he doesn't have a cardiac issue yet. We are screening it couple of years down. Every single test has been done, but he is extremely fatigued. Is there any special test that we need to do from a pulmonologist standpoint to understand if his lung function or the capacity, oxygen, carbon dioxide, whatever? I don't see him snoring, but I don't have enough expertise to speak about it.
Yeah, he should see a pulmonologist and have pulmonary function tests done. We do essentially 4 tests: spirometry, which is the standard test that most pulmonologists do. So that's take a big deep breath, blow it out hard and fast, and we measure how much air comes out. Then we have 3 respiratory muscle tests: the maximal inspiratory pressure, how hard you can suck in, right? Maximal expiratory pressure, how hard you can blow out, and then the peak cough flow, or cough peak flow, which is how fast does air come out when you cough. Those are really our 4 best measurements of respiratory function. They certainly don't mean everything in breathing dysfunction, because that's one moment in time, and we breathe all the time, right? We breathe almost as frequently as the heart beats. We shouldn't. Yeah. Yeah. Your respiratory rate and your heart rate should never be the same. Not healthy. It's a joke. But so he should see a pulmonologist. The other important pulmonary function test is a sleep study if he's having symptoms of issues with breathing during sleep. And there are many symptoms that can be subtle that we can talk about perhaps elsewhere, unless you want me to go into that now.
Thank you.
So you talked about arrhythmias, and I was curious. I know it's hard to sort of separate genetics from, you know, those types of things, but is there research out there on Titin and like arrhythmias without, you know, like say, or without muscle changes or?
We have some early data to suggest that AFib is more common in young people who have Titin variants prior to the onset of the cardiomyopathy. So the heart muscle can still be squeezing normally, but you present with episodes of AFib. And then at some point, it can progress to the cardiomyopathy as well. In others, they just remain with the AFib. There's another structural abnormality called non-compaction, where the heart muscle looks spongy. That can also be associated with Titin. And again, getting an MRI is often the best way to find those more subtle things. And a Holter monitor can help you to find the arrhythmias. But yes, we do see them even before the onset of the cardiomyopathy. We sometimes also see extra heartbeats from the bottom chamber that are called premature ventricular contractions, or PVCs. Those can come even before the cardiomyopathy.
I also, on the note of arrhythmias, is Dr. Benjamin Shoemaker at Vanderbilt is doing a clinical trial now and enrolling patients with Titin-related inherited heart conditions as related to arrhythmias. And so that information is available in our Facebook group and on our public group and privately. It's also on clinicaltrials.gov. You can find the study there. And you can talk to that team, and they also do an educational meeting if you just need some more education to talk to them about what that involves. There were two other things I want to talk to you about since we're not done, which is one of the things Dr. Ernie and others have talked about is something called penetrance, which is that if you have a Titin truncating variant, for example, and how do we know, a lot of people are walking around with these variants, and how come they're not all walking around with heart health problems? And one of the, Dr. Diane Fatkin just undertook a huge research study on this, and they studied, I think, thousands of people and looked at what was some of the factors that kind of led towards greater penetrance for people with Titin truncating variants and what was protective. And it's super informative, and I can't share the information right now but because it's been accepted for publication, but I can tell you that Dr. Fatkin really wants to work with our community for pushing this information publicly so that if there's actionable items that our community might be able to take or learn more about or avenues for additional research. So stay tuned on that. More information is coming. And because it just really, we need just keep peeling back the layers of this onion. And the other thing I was going to talk about is exercise, and I'll ask you guys to talk about that. And a couple things about it is that there have been several publications related to Titin variants and exercise, in particular, is related to heart health. And a recent study from Dr. Fatkin and their group, and we have been pushing some of that information out on social media. And some of the take-home points of it are, number one, that one size does not fit all, that this is need individual working with your team, like this wonderful team we have here. And the second thing is that exercise, there had been, depending on different groups, that some thoughts that exercise might be harmful, but there is some thinking that it might be beneficial, and that you need to talk to your team about what's right for you, what's good fit for you, so that you can keep that on your radar, and I'll ask you guys to talk about exercise. And I also want to make a plug for, we have a very special speaker who is a specialist in exercise. She's a rehab doctor, came all the way from Netherlands to talk to us about exercise. And that is her research focus. She wrote what's called the Cochrane Review on Exercise and Neuromuscular Disease, which is like a kind of special review of a lot of literature. And she's done her own research, and that's Nicole Foot. and she's going to be talking tomorrow at the plenary session at 11. So I invite you guys to check that out. And I did send her our Titin papers about exercise so that she would have that in her mind when she gave that talk. But I'll turn it over to the panel to see what you guys, because a lot of people ask about exercise, and exercise meaning activity, and I understand for people with skeletal muscle conditions, activity may look really different for different people based on your functional levels. So anyway.
Yeah, I mean, I would say it's certainly not one size fits all. I mean, I think that everyone is individual, specific, based on what your cardiac function, whether you have arrhythmias, whether you have electrical abnormalities, and so I think it's individualized to every single patient, and involves what we call a shared decision-making process between the patient and their team about what what they desire, how to get them there, and what they may need to get there. I'll put in one plug on the adult side, at least, that in certain populations, especially if you have a cardiomyopathy with a certain ejection fraction level, usually less than, I believe, 35%, cardiac rehab as a prescription of supervised exercise is very, very beneficial. I've heard universally from my patients that they, over 36 sessions, which is over 3 months, achieve a significant benefit just from having supervision of their vital signs before, during, after exercise, having someone guide them in terms of when to push the boundaries, and having the peace of mind just to understand what they can do, whether or not they have limitations.
I think that's great. I think not much to add to that. I do think we are pro-exercise. I think as a field, the shared decision-making model in patients, even who have heart muscle involvement, we know the downsides of restricting patients from exercise, particularly, I could speak to children's and the psychosocial impact of, being different than your peers and being held back unnecessarily. So I think when you think about neuromuscular patients, there are other strength-related factors that might play into what activity you are looking to do. From a heart muscle function standpoint, if you have some degree of heart dysfunction, we do more testing, like an exercise stress test that's been brought up before. I would say, generally speaking, our patients who have advanced heart failure are not asking to exercise. We're trying to manage their heart failure, to a state, but I think we are pro-safe exercise. We do a lot of discussion with families. What does safe exercise look like? Where is the exercise going to take place? Most school facilities have things like AEDs, defibrillators. So we just talk in detail about the safety of exercise if there is heart muscle involvement, but we are very much pro-exercise with safe measures.
One last point, there are a couple of genes where we know if you have a change in those genes and you exercise high load activity over years and years, it can cause your heart to get progressively worse. Titin is not one of those, so we don't restrict exercise. We don't have any data to suggest that it will make your heart function worse. So it's an important distinction from a couple of other genes that we do know.
Exercise is good.
I want best practice questions. I have 3 people with Titin mutations, different ejection fractions, right? So if you could answer in terms of if you have a normal ejection fraction or a lower ejection fraction. Clearly, I think everyone in the room knows the difference between an echo and an MRI. So, but I find that insurance companies are like, oh, you can get an echo, but the MRI we're not going to approve. And so they've said, in regards to my children, your echoes have been okay. We're not approving MRIs. So sort of what's the, like, is MRI definitely the gold standard, or you really should have it? Or if your ejection fraction's okay, you really don't need it and you can let that go? Where do you have the fight with the insurance company, or what's best practice?
Yeah, the difference between the echo and the MRI in terms of what information you could get is really a closer look at the heart tissue. And the one thing you can see on MRI that you cannot see on echo is scar tissue. and inflammation. So if your team is thinking there may be scar tissue building or inflammation of some type, if there's electrical abnormalities, but the heart muscle is normal by echo, that's often a time where we move to the MRI to say, is there something more subtle going on at the tissue level that ultrasound can't see, but MRI can? So if your team were to write in, I'm looking for scar tissue or signs of inflammation, the insurance will take it because they know that MRI is the only way to get that. And then the second point really is that, do you need that all the time? No. We usually use MRIs once every 3 to 5 years, unless there's a major change. The other part about echo is that sometimes because of where your ribs are, you just can't get the right window to look at the heart. So if any part of the heart is not well seen, that's the other time to get an MRI, because the MRI doesn't matter where the ribs are, it sees right through it, if you will. And so your pictures are really beautiful regardless of what your chest wall limitations are. So if any part of your heart is not well seen on ultrasound, insurance will approve an MRI, typically.
I would ask also Dr. Wang, at the limb-girdle conference, we heard from, which is a different population, but in the dystrophies, they've been doing some research, and we're talking, Dr. Khan Hoare from, I'm sorry, I can't remember his institution at the moment. Okay, anyway, he was talking about really the critical importance in the neuromuscular population for the benefits of MRI. So I don't know if you want to touch on that.
Yeah, and I think that, there's a lot of, I'll back up a little bit, because I think with the neuromuscular conditions, they're very, very heterogeneous, as we would say. They're all different from one another. And the way that we kind of approach them from a cardiac standpoint is I kind of think of 3 buckets in terms of the cardiac effects of the neuromuscular condition. One bucket is cardiomyopathy. Is there a change in the muscle function of the heart? Second bucket is, are there abnormal heart rhythms, whether they're coming from the top or the bottom chambers? And then the third bucket is there any abnormality in the electrical system, what we call conduction disease? And so these are kind of the 3 buckets that we think about when it comes to neuromuscular conditions, and every one of those neuromuscular conditions, whether it's Duchenne, limb-girdle, Emery-Dreifuss, myotonic dystrophy, Titin, congenital myopathy, Nemeline, all of those are different in terms of which one tends to predominate or where we see that information. And it's, unfortunately, we're quite limited. Now, Duchenne, I think probably has Duchenne and Titin maybe have the most information and knowledge that we have seen from publications, and everything else is probably even less than that. And when you get into even like congenital myopathies or Nemeline, the cardiac effects are really just case studies. So I think that, I'll get to your question in a second, Sarah, but I think that having an understanding of which of those kind of buckets tends to predominate in each of those neuromuscular conditions matters. And not all 3 are present in every single neuromuscular condition. Some are very, cardiac effects are very rare or not seen, or not described, I should say. But certainly I think cardiac MRI helps us understand whether or not there's underlying scar in the heart muscle tissue that helps us understand, okay, does that apply to any of those 3 buckets, if that makes sense.
Thank you. The other thing I can't believe I forgot to mention until now, which is that the Genetic Cardiomyopathy Awareness Consortium has a free cardiac genetic testing program going on now with an organization called EveryGene. And it's actually the criteria are you have to be in the US and you need to have been diagnosed with a cardiomyopathy, they do accept retesting. So if you haven't had your genetic testing in a while, or you had a VUS that hasn't been clarified, which we just heard about, that this program is available, and they are asking people, if you have cardiomyopathy and you want to get retested, and one of the things that they're doing is actually collecting, along with the genetic information, clinical information, extensive clinical information. And the idea is to try to drive forward with a large data set the opportunity for treatment and understanding that this actually becomes a data issue in a way. And so this is this and so it's there's information. They had a webinar about it just recently, and the information is in our Titin Facebook group, and it's also, you can find it on the Genetic Cardiomyopathy Awareness Consortium website, or if you just probably Googled free cardiomyopathy genetic testing, it would probably come up, or Every Gene is the company. And by the way, the testing is being done at the Broad Institute, so and they have some really strong affiliations. I'm not certain. Oh, do you want to talk more about it?
Happy to. So we're working with them a bit, but I don't believe they're going to return VUSs, but if they find a pathogenic, likely pathogenic, they will return that at this point. At some later point, they may return VUSs, but it is a new platform, and the sequencing is done at the Broad Institute, so very high quality sequencing. And they are looking to channel patients into trials if they're interested as they come available. So I think it is a reasonably good program to look into. Yes.
So I think the criteria are you have to have symptoms of heart disease, and then one other thing, which could be a family history. I believe it's a new program, and it's by Invitae, and you can the clinician can select a different panel, but it is panel, and you can do the comprehensive cardiomyopathies panel with some clinical criteria that are pretty easy to meet for most people in our community. And that's on the Invitae website. Could I ask a question about the medication? So how does the medication for cardiomyopathy work? And since it apparently is not specific for whether it's genetic or not, does that mean it's kind of like it's working at the end stage? And is there any application for narrowing it down or even applying some of that medication for people with skeletal muscle disease?
Great question. So the 4-pillar therapy that I talked about is generic for anybody with a low ejection fraction. And so because of that, it does work on what we call the neurohormonal pathways. So the sympathetic nervous system, the renin, angiotensin, aldosterone system. This is all Greek, but it works through the hormones of the body. So it, and that's why a beta blocker is used to combat your adrenaline system. We use the angiotensin receptor blockers and neprilysin inhibitors for the kidney system. So it all helps your heart to be able to do less work. Opens up the leg blood vessels so it's easier for the heart to pump forward. It quiets down the adrenaline so you're not beating your heart as quickly. There's medicines that help you to pee out extra fluid. So those are those kind of generic pillars of therapy. The more targeted approaches are coming, and that's one that I mentioned, a myosin activator. That's going to be targeted to the cardiac sarcomere and cardiac myosin, which is the motor unit of the heart. As Zolt said, it's the part of the heart that squeezes. And so when you attack the motor, that's targeted, and that would be poised to help patients with Titin-related cardiomyopathy. That's a trial that's coming. Small trial was done, but now they're going to go into a larger trial, and the drug is danicamtiv, so that will be on clinicaltrials.gov. And that's a very targeted approach. However, you can select a molecule that's cardiac specific or skeletal muscle specific. They have opted to go to cardiac specific, but there are other myosin activators that are developed and being trialed for skeletal muscles. So, yeah.
A slightly different way of thinking, or same, but worded differently. The way to think about the current 4 pillars, which are in fact generic, is that when you have a cardiac insult, whether it's Titin caused or ischemia caused, your body doesn't like it. And your body reacts, and it reacts hormonally and neuronally. And that reaction over time makes the heart even worse. So what we're doing with those 4 pillars is blocking that reaction. So we're actually not treating the heart. We're not touching the heart with those 4 pillars. We're blocking the body's response that makes the heart worse. So at some level, that's not entirely satisfying. We'd like to fix the heart, which is why drugs like these that are coming down the pike are exciting, because we may actually be getting at the root of the problem, potentially.
We're going to wrap up here, but I just wanted to also mention is that we have on our website, the titinopathy.com/care is the Global Heart Hub Friendly Guide to Heart Failure. And even if you don't have heart failure, it's really easy to read and explains the 4 pillars. And I give it to a lot of the new families that I connect with who ask for heart health information. And the title of heart failure can be kind of scary, but it's kind of actually good to understand. Talks about symptoms, what to monitor, and then it explains some of these treatments in a very friendly language with good graphics and stuff. So you can check it out there. But I just want to thank all of you for being here. Yeah, sure.
This is on a slightly different wavelength, but I just want to get this in there. So I would like to ask for your help. By and large, most of what we do, all the research we do, is funded by our government. And that's a little bit at risk these days. And congressmen and congresswomen listen to you a lot more than they listen to us. So my ask is send letters, call your congressmen and women, and let them know that this is important. That's my ask.
So guess what? We have a whole topic about that tomorrow because we know how important it is. And there's 2 speakers in this room who are going to be part of that talk about advocacy. I want to thank all of you for coming today and for the families for sticking with us. And just remember tomorrow, okay, we start at 8 in the morning, but please know there will be breakfast beverages served in the back. So you can come and get your favorite beverage.
It was a 10-minute wait for somebody today. So if you need to be somewhere at 8, 7:45.